Hi everyone, my name is Leslie. Today I'm going to be doing a case report on an elderly patient who is presenting in an altered mental state secondary to a hypercapnic encephalopathy. This was a case that I had on an inpatient internal medicine rotation where I was up in Eureka, California. So I chose this case for a couple of different reasons. The first being this was my first start to finish admission. The ED providers consulted internal medicine, and my attending gave me the opportunity to go down into the ED and get my own history and physical and perform my own diagnostic tests to come up with the diagnosis and treatment plan. So it was a really good experience. I was also able to have my first code status conversation. In this case, it was with the patient's husband since my patient was in an altered state. I also chose this case because encephalopathies are really interesting to watch and see them through, because once you find the underlying cause for their altered mental state, you truly just reverse it and they come back from it pretty quick. I don't mean to oversimplify the treatment plan, but once you find the underlying cause, you just treat it and then their consciousness reverts back to their normal baseline. This patient also had a long list of comorbid conditions that were ultimately worsening their presentation, which complicated the case quite a bit. Also, acid-base disorders are something that I find very difficult and challenging, so this was an opportunity for me to address a deficit in my knowledge. So I'll go ahead and present my patient. I had an 82-year-old Caucasian female who was brought into the ED by ambulance, accompanied by their husband. They were presenting in an altered mental state. They had last been seen normal the night before, after having dinner and getting ready for bed, as they did every day. They were wearing their O2 when they went to bed, but upon awakening the next day, the patient had slept in and they weren't responding. And so then as the day went on, the husband started to get worried and decided to call 911 and bring the patient to the ED. Past medical history for the patient includes chronic hypoxic hypercapnic respiratory failure, for which the patient wears 3 liters of O2 via nasal cannula 24 hours a day, osteoporosis with severe kyphoscoliosis, AFib, systemic sclerosis with Raynaud's, interstitial lung disease, pulmonary hypertension, CKD3, and hypothyroidism. Family history was not necessarily pertinent for the current presentation, and there was no history of smoking, drugs, or alcohol. Med list included omeprazole, sildenafil, levothyroxine, furosemide, docusat, and diltiazem. There were no known drug allergies, but there was a contraindication of using nitroglycerin, as this patient was already on a vasodilator, and that could result in a significant drop in blood pressure. Surgical history was not pertinent at this time for the current presentation. Physical exam findings: the patient's vital signs were relatively stable. Their heart rate was a bit tachy at 114, and their O2 saturation at this time was normal at 96% while on BiPAP. The patient looked ill-appearing. There were no acute distress, but they just appeared to be as if they were sleeping. Their skin was warm and dry without any jaundice. Their head was normal cephalic and atraumatic. I was unable to assess their pupillary responses or EOMs as they were altered. Their heart was irregular. They were in an AFib. They were tachycardic, and there were no audible murmurs, rubs, or gallops at this time. On pulmonary exam, there was decreased airflow kind of globally in both lungs. There was no audible wheezing, rhonchi, or rales appreciated, and the patient was on BiPAP when I went down into the ED to evaluate them. Their abdomen was soft, with normal active bowel sounds and without any distension. MSK was significant for severe kyphoscoliosis. On neuro exam, their GCS coma scale was a 3. There was no pupillary, audible, or motor response, so I was unable to accurately assess their cranial nerves at this time. So as far as a differential diagnosis goes for an altered mental state, my attending provided me with this mnemonic MISTY, where the Y is a psi for psychiatric conditions that could be resulting in an altered mental state. And so on the left-hand side, I have your general, very broad differential for the things that could be causing a patient to be presenting in an altered state. And on the right-hand side here, I have my patient-specific differential, and I'll get into that in just a bit. So just to kind of work through this mnemonic, the M stands for metabolic. Etiologies of an altered mental state, whether that be an electrolyte abnormality, an acid-base disorder, increased ammonia levels, irregular thyroid levels, glucose levels, thiamine, or B12. The I stands for infection, so you want to consider doing a blood culture for any patient presenting in an altered mental state to assess whether or not they're in a bacteremic state. You want to do a urine culture to rule out or rule in a cystitis or pyelonephritis etiology. You can do a chest x-ray to evaluate for pneumonia and a lumbar puncture to evaluate for meningitis. There are also structural components that can be presenting in an altered mental state, including a stroke, an MI, or a PE. Toxins is what the T stands for, so you want to take a look at your patient's med list to see if there are any drug-drug interactions that can be causing the patient to be altered, or if these are recreational drugs that can be causing a patient to be altered as well. The Y or the psi is for psych, so whether they're in a catatonic state, if they're schizophrenic, or if they are malingering. We had a large homeless population, so that was something that we saw quite often. As far as the differential diagnosis for my specific patient, the first thing that we were considering was an acid-base disorder, given their long list of pulmonary pathologies at this time. So we did order an ABG. We also considered electrolyte abnormalities because this patient also had CKD, stage 3. We considered hypothyroidism. Maybe they weren't taking their medications as they should have been, and they were presenting in a mixed edema coma. We wanted to make sure this patient wasn't having a UTI or a pneumonia. I think this is something that we learned in undergrad, where the elderly or the geriatric population is much more susceptible to infectious etiologies. So this is something that we took very seriously in our 82-year-old patient. Polysubstance, I can go back, but this patient was on quite a lot of different medications, so we kind of went through those to see if there was any drug-drug interactions. You also don't want to believe that your 82-year-old cute little old lady is on any drugs, but you definitely want to keep that in your differential to make sure that that's true. In Humboldt County, where we were, I did see a lot of meth use, and the majority of our population was geriatric. So it's just something to consider on your differential. And then we also wanted to ensure that our patient wasn't having a stroke or a hemorrhagic etiology for their altered mental state presentation. So these are the labs that the ED did upon arrival. So their initial ABG showed their pH level was 7.17, so they were acidotic. Their CO2 levels were higher than we wanted them to be. We want them between 35 and 45, and they were way on the higher end. They were at 118. Bicarb was also on the higher end, so there was signs that the kidneys were trying to compensate. Their glucose levels were higher than normal, but not significantly high, where I was super concerned. Their BUN was also higher than normal, but could that be due to their CKD? That's also very likely. Their serial troponins were 52 and 45. We did an EKG to ensure that this patient wasn't having a MI, but both the serial troponins and the pro-BNP that was elevated could likely be due to the interstitial lung disease that was causing stress on the heart. So that's what we were attributing those to mostly. On imaging, this was my patient's actual chest x-ray. As you can see, their shoulders aren't aligned, so there was some significant kyphoscoliosis taking place that decreased their lung volumes, and there was significant interstitial lung disease, likely secondary to the systemic sclerosis this patient had already had. The ED also performed a CT of the head that showed no acute pathology, so that made a stroke less likely at this time. Upon admission, we did a repeat ABG, and their pH did begin to normalize. It went from 7.17 to 7.32. Their bicarb decreased once they were placed on BiPAP machine, and their oxygen level also went down. Their bicarb levels also began to normalize. Their repeat electrolytes and LFTs were within normal limits. As I mentioned before, their BUN and creatinine their creatinine was normal, but their BUN was elevated, and that could likely be due to their CKD. Their thyroid levels were within normal limits. Their initial CBC and repeat CBCs were also within normal limits. We did do a UA that showed positive for proteins. That could be due to a lot of different things associated with their lung pathology, but it didn't show any nitrites or bacteria, so that made a bacterial infection less likely at this time. I forgot to mention that on their chest x-ray, we couldn't visualize any lobar consolidations, also making pneumonia less likely at this time. So as far as their assessment and plans go, the initial reason or the overall reason why this patient was altered was because of a hypercapnic encephalopathy. They were simply retaining too much CO2. However, the body wasn't able to sense the excessive amounts of CO2 because they were always on their nasal cannula of 3 liters O2. So the body doesn't sense that their CO2 levels are off because their O2 saturation is within a normal range, so they doesn't think that anything is wrong. So these things were exacerbated because of the acute on chronic hypercapnic respiratory failure, the chronic hypoxic respiratory failure. We were suspicious for sleep apnea in this patient, and then the severe kyphoscoliosis also worsened the patient's lung capacity. They were not able to expand fully because of structural anomalies in this specific patient. So we placed them on a BiPAP, and they were able to blow off that excess CO2 because that's what the BiPAP does, right? It blows air into the lungs, but it also sucks it back out, so you're not retaining all of that CO2. We were concerned about the elevated troponins this patient had, but because of their EKG findings, we were less concerned of an MI at this time and attributed it to the pulmonary hypertension, which is the same thing that we did for the elevated pro-BNP. We didn't think that they didn't have a history of congestive heart failure, and their chest x-ray didn't show any signs of cardiomegaly or fluid retention, so we attributed the elevated pro-BNP to the pulmonary hypertension at this time. Which was also exacerbated by their interstitial lung disease, which is due to the systemic sclerosis. So like I mentioned previously, this is a really complicated case with a lot of different moving parts. We kept them on their sildenafil and their furosemide and albuterol as needed while they were admitted into the ICU under our care. Ultimately, this patient responded to treatment very well. Their pH normalized after a day in the ICU, and they were able to blow off that excess CO2. They discharged from the ICU after 2 days. They did, however, have issues with compliance on the BiPAP machine. It's not very comfortable to have this machine that was like forcing air into your lungs and sucking air out of your face, so it's not comfortable. So this patient wasn't the most compliant with treatment. Unfortunately, they were readmitted to the hospital about a week later. They weren't under my care at that point. I was working with a different attending, but the attending that I did this case with brought it to my attention that they were readmitted and unfortunately didn't make it. I don't know why they didn't make it. I didn't read any of the reports because, like I said, they weren't under my care, but one can suspect that it was likely because they weren't compliant to their BiPAP machine on top of all of their other comorbid conditions that could have been exacerbating this patient's presentation. And so overall, strengths for this case, thankfully, we had all of the resources we needed to perform a full workup for this altered mental state patient, and we were able to rule out more serious causes and get to the bottom line and treat the underlying condition. The husband who brought the patient into the ED was also super informative and very helpful, involved in his wife's care, and he was able to answer a lot of the questions. As far as limitations go, while the husband was a very helpful tool and components to getting the correct answers, it's also not first line information from the patient, so that also just created some barriers with it. Like I mentioned, the BiPAP machine was not comfortable for this patient, so that was part of the reason why this patient was having a difficult time complying with treatment. It can also get pretty dangerous, right? Because it causes suction on your face. So if you were to ever vomit while you had your BiPAP machine, it can just go into your lungs, and then you're dealing with an aspiration pneumonia at this time. Key takeaways from this case is to keep your differential broad, but to also be patient specific. So you don't want to do what we call shotgun medicine and order all of the labs under the sun because they're not always needed, right? So just make sure to keep your diagnosis and your treatment specific to your patient. As far as treatment versus resuscitation goes, my patient ultimately was DNR, but just because they were DNR status doesn't mean that we were going to treat their hypercapnic state, so just always know that difference. And then as primary care providers that Toro trains us to be, we are used to treating chronic conditions, but ultimately these chronic conditions are what kill us at the end of our life, and that's just kind of a lesson that I had to learn while on this rotation, and ultimately what I'm assuming is what took this patient's life at the end of her care. As far as acid-base disorders go, I'm still not a fan of them, but they are never going to go away and they're going to show up on the pants. So this was a good learning experience for me to address a deficit in my knowledge, and I definitely feel much more comfortable with them. And these are my resources, and that is all I have. Thank you so much for your time.